Hello everyone, we're here in the meeting. I'm here with Dr. Tanios Bekaii-Saab, the head of oncology at Mayo Clinic. And also Tony is one of the leading experts in GI cancers all over the world. And he's going to talk a little bit about KRAS inhibitors, not just in pancreas cancer, but all cancers, colorectal cancer and others. So Tony, what do you think about the data that we have today and the future in the field?
Well, I think that, the RAS, what we call now the RAS revolution has started. Started a little bit with G12C mutations. We had two agents, adagrasib, sotorasib, and to just show us good proof of principle. And then with colorectal cancer, adding an EGFR inhibitor, so we start seeing, at least in GI cancers, these responses happening. And then when you heard about daraxonrasib in pancreas cancer, just transforming this disease. So the question is, what next? What next is, how do we take these advantages in the later lines of therapy and bring them to earlier lines of therapy and even to the adjuvant and neoadjuvant stages? So in pancreas, we're seeing daraxon, but we're also seeing a number of 12D inhibitors, zoldonrasib, the Incyte compound, and others move now to the first line with chemotherapy, but some strategy without chemotherapy, because some of the data is looking, at least in pancreas cancer, that single agent can do as well, if not better than chemotherapy. So for some you may need chemotherapy, for others you may not. And then what I'm also very excited about, since we're seeing that these inhibitors change the biology of the disease, now we're moving to the adjuvant setting, to the neoadjuvant setting. So how can you bring more and more patients who are potentially curable to a full cure? So I think we're going to change that. And we see also biliary cancer and colorectal cancer also following the same path with 12D inhibitors in colon cancer, which is a very large proportion of patients. Those patients don't have a lot of options. We're going to expand our options. Biliary cancer, 10% of those patients will have a RAS mutation. We're going to expand their options as well, multiple lines of therapy. So we're really seeing the tip of the iceberg with the data that's available to us today. And I think, 2-3 years from now, it's going to be pretty much every cancer we treat.
Nice. Great to see the evolution that we have today in KRAS and other fields as well. Thank you, Tony, to be here, and let's go to the meeting. Thank you.
All right.